this session.
Thank you very much for that very kind introduction. Greetings from Tata Memorial Hospital. Greetings from Mumbai. At the outset, I'd like to thank Professor Subhash Todi and the entire team of AMRICON. I have been very fortunate to be physically there for several meetings, and I think this is really one of the very innovative meetings that are being held in the country, and I really look forward to it every year. Unfortunately, this year I'm online, but not recorded, at least live. So I'm really happy to speak to all of you and interact with all of you. So thank you very much, Dr. Todi, for giving me this opportunity, and also special thanks to the entire team, especially Dr. Pinaki Datta, who's really assisted me quite a bit with this, organizing this. So I will be speaking. Dr. Todi has given me a whole list of topics, and I have 2 sessions of 30 minutes. First of all, apologies. I was supposed to take this in the morning, but because of some personal reasons, I was unable to be present. So I will take it one after the other. What I've done is I've combined both the talks. So I'll be with you for 1 hour. I will try to make it as interactive and interesting. I know it's at the end of the day, so it can be quite a lot of scientific overload for you. So what I'm going to do is, since there are many topics that I have to address, it won't be possible to go in depth into all the studies, but I'll give you a broad overview, and I'm happy to take questions at the end of it. Unfortunately, because these are studies related to 2021, most of the work is on COVID related studies, and a lot has already been covered on COVID. I saw a lot of overlaps with some of the studies. So in those studies, I'll just go through them very quickly. But my objective is just to give you a broad overview, tell you about the key studies. There may be some, of course, that I may have missed, but also to stimulate you to go ahead and look at that paper and read it further, and perhaps it can help you and guide you in your clinical practice. So I'm going to start with airway, non-invasive ventilation, COPD, asthma, and pulmonary embolism. I'd just like to ask, can you see my screen?
Yeah.
Thank you so much. So these are the topics I'll cover first, and after half an hour, I'll switch over to the other set of topics. So I'll start with the first topic, which is something that's very dear to my heart, that is airway. And the first study I'm going to be talking about is also a very dear study, and that is the INTUBE study. So there are 3 very big airway papers that have come in 2021 that are very important and also practice changing and are very important for us to know about. And I'm very fortunate to have been involved with this first study, and this is called the INTUBE study, and this was published in Jama. I'm very proud to be the second author on this paper, and I'm also very proud that almost 60 centers from India participated in this study. Now, what is the INTUBE study and why did it find its way in JAMA? We know that the incidence of complications in critically ill patients are much higher than that seen in the operating room. We've had, small series, national audits, but we don't have any global data that involves the developing world, developed world. So this was the first global study that was conducted to look at intubation practices in critically ill patients and also to look at adverse peri-intubation events in critically ill patients. So it was a global real world study, observational study. And what they did is they took the first 20 intubations that you did over a period of 6 months. And as I mentioned, we had almost 60 sites from India participating. And I'm very proud of this study because it was truly a story of global collaboration. I met these 2 gentlemen, Giacomo Bellani, as you all know, he's with the Lung Safe study, and respiratory experts. I met him when I was giving a talk in Hong Kong at ESICM, and I was talking about tracheal intubation in the ICU. And he was chairing the session, and he was, just listening, and he was thinking, oh, here is somebody who's very, familiar with airway management in ICU, doing work, doing research. And after the talk, he said, I'm planning a study in Italy. Why don't you collaborate from India and we can do this together? Soon this became a study of Europe. And I said, why do you want to make it only of Europe and India? Why don't we go global? And that is the reason that this paper made its way to the JAMA. And I'm really proud of my colleagues in India who tremendously supported me and contributed to this fantastic piece. So what we were trying to do was just look at the practices of tracheal intubation in ICU and, look at global data look at the complication rates. As I mentioned, we only had small series until now. So it was an international study. We looked at consecutive 20 tracheal intubations in the ICU. We didn't want too many intubations from one site and very few from the other. So the first 20 tracheal intubations over an 8-week period that was done. And we took only adult intubations. We didn't include out of hospital intubations or intubations in non-critically ill patients or following cardiac arrest. And the primary outcome was that within 30 minutes, if you had severe hypoxemia or cardiac arrest or cardiovascular instability, this would be looked at as a event. And of course, we also looked at certain secondary outcome. 197 centers, 29 countries, and you can see India is quite dark purple over here, and over 6 continents, and these were the centers that were involved. So it was truly a mix of different countries and different economies. Now, I'll just give you the key findings. These were just the indications for intubation. Now, the reason for intubation in almost 50% of the patients was respiratory failure, followed by neurological impairment. But if you look at the peri-intubation events that occurred, the highest complication was actually cardiovascular instability, followed by severe hypoxia, and followed by other complications. So though the indication was respiratory failure, the incidence of cardiovascular collapse was quite high. And this was actually really a surprise finding, because all along we are worried about hypoxemia in critically ill patients. So just to appreciate this better, if you look at the overall complications, it was close to, almost 1 in 2 patients had a complication. That's really high in a critically ill patient. And 42% of the patients who got intubated had cardiovascular instability. So the incidence is quite high. And severe hypoxemia was 9%. It was almost like a reverse. The indication for tracheal intubation in cardiovascular for cardiac reason was about 9 to 10%, but the incidence of hypoxemia was 9%, followed by cardiac arrest. And here you can see it pictorially that the highest complication was cardiovascular instability. So this is really a wake-up call when we do tracheal intubation in ICU. It's a very high risk procedure, and we have to acknowledge that hemodynamic instability is a real finding. Almost 1 in 2 patients get it. There are multiple reasons why we get these findings, and we have to do various things now to look at how we can mitigate the risk. These were the secondary outcomes in the study. And the other interesting findings was, if you look at video laryngoscopy, we talk a lot about video laryngoscopy. Only 17% of people in the world are actually using video laryngoscope. And this was not a story of the developed world. This was also the story of the developing world. So though video laryngoscopy is very highly used in the operating room, it's almost negligible even in the developed world. And this will definitely increase your chance of first pass intubation success, and utility of this is very, very low. So we need to train to use it. Use of Stiletto was higher than that of Bhuji. I'll come to study related about that. But the most disappointing finding was people are still using auscultation to confirm that the tube is in the right place. Only 21 in 4 people are using capnography, which is the gold standard to confirm tracheal intubation. A single esophageal intubation can result in very high risk of complications in these patients. So this is in fact a really surprising finding, that even in the developed world, people are not using capnography. In the operating room, we cannot imagine giving a single anesthesia without the use of capnography, but this is almost a non-existent practice in the ICU, and this is a real wake-up call for us. And the other thing was the use of propofol. Now, propofol is a very good drug that you can use because it upturns the intubation response, but in critically ill patients, where the incidence of hypotension is so high, a drug like propofol in someone who's already hypovolemic with intravascularly depleted can result in precipitous fall in blood pressure. And propofol is not a good drug, and etomidate and ketamine are recommended for tracheal drugs for induction tracheal intubation, and these are present in all the guidelines. However, it was surprising, and this may be one of the reasons why the incidence of hypotension was so high in the critically ill patients. Another important finding was that repeated attempts were associated with severe hypoxemia and cardiac arrest. If you look at even from first attempt to 7 attempts, a second attempt or third attempt, there was a significant difference if you look at overall complications, cardiac arrest, and severe hypoxemia. So a very clear message that unlike in the operating room where you can do 2 or 3 attempts, you need to limit the attempts at tracheal intubation in the intensive care unit and try to optimize first pass intubation success. And video laryngoscopy is one of the ways of doing that. But sadly, the utility is very low across the globe in ICU patients. Now, this is a very interesting study and as a finding, and you can see the Kaplan-Meier curves. And here, this is the first study that showed a mortality difference due to complications that occur during tracheal intubation. And here you can see that patients who experienced an overall, cardiovascular instability or cardiac arrest had a higher risk of, so 28-day mortality was higher. So during tracheal intubation, the complication that you could have has actually resulted in an increased, mortality. So it's one of the first studies that demonstrated a mortality difference following a complication during tracheal intubations. So a lot of important findings. This was, of course, not a randomized control trial. It was an observational study, but high frequency of complications, number one. So tracheal intubation in ICU should not be taken lightly. It's not about just putting the tube in. Very high risk environment, very high risk patient, and complex environment making tracheal intubation very difficult. And in addition to this, one must acknowledge that cardiovascular instability is a complication. So we must consider preloading with fluid or giving vasopressors to these patients early. The study from Vanderbilt has actually shown no difference when patients are preloaded. So perhaps there is a role of the early use of vasopressors in these patients to avoid hypotension. So this future study should focus on interventions on how we can mitigate this risk of hypotension. But the first thing is to acknowledge that hypotension is real and patients following tracheal intubation have hypotension. And we've become sort of quite good at peri-intubation oxygenation. So probably that is the reason why the incidence of hypoxia is less. The second study I want to go into is the Stiletto Trial. Now, this was from the group of Samir Jaber, multicentric study from France, 999 patient randomized controlled trial. Now, very interesting study. He did a very simple study, and this is with the use of direct laryngoscopy. Now, it's called stiletto because in one arm they use a stillet with the endotracheal tube, and the other arm they use just a plain endotracheal tube. Now, why do we use a stillet? We use a stillet to pre-shape the endotracheal tube so that in case you have an anterior larynx or a difficult intubation, you can put in a stillet and then try to intubate the patient. So usually this is done as a rescue. But what Professor Jaber did in this multi-center trial of 32 intensive care units is he used the stillet upfront, not as a rescue, but as first line during tracheal intubation in one group, and in the other group, the stillet was not used and direct laryngoscopy was used. Now, the main findings in the arm where the tracheal tube was used with the stillet versus the tracheal tube alone, there was a significant difference. The primary outcome was first pass intubation success. And, this occurred 78% versus 71%. This was significantly different. So there was a clear benefit of using a stillet. And we, as I mentioned, that the complications are very high in these patients. So anything that you can do to increase first pass intubation success is going to be very useful. And, this simple study has clearly demonstrated that perhaps in critically ill patients, we should not use the stillet as a rescue, but we should use it as a first line. So the clear message from the Stiletto trial, this randomized controlled trial in 999 patients, is that the use of a stillet for tracheal intubation has resulted in significantly higher first pass intubation success than the use of tracheal tube alone. And in addition to this, there was no difference in the traumatic injuries or serious adverse events, because people are worried when they put a stillet in, there might be some trauma, but that did not happen. No difference in complications. So clear message that we can go in with a stillet for all tracheal intubations and not use it as a rescue during airway management. Very recently, another study that's come is the Bhuji Trial. Now, this also was a study that was published in Jama. So two big airway studies that have come in Jama in this last year. And what was a Bhuji Trial? Now, Bhuji Trial did something very interesting. Just like you have a stillet, you also have a Bhuji, which you can use. So when you do a laryngoscopy and you see the larynx, you see only a partial view of the glottis. You put in a Bhuji, and then you can railroad the endotracheal tube over that. So it takes two steps, put in the Bhuji first and then the endotracheal tube. Nevertheless, it can increase your chance of first pass intubation success. So what they did, this group at Vanderbilt, they did a randomized controlled trial comparing the Bhuji with the endotracheal tube and a stillet. So what Jaber used was the endotracheal tube and the stillet, and they compared it with the Bhuji. And again, both these techniques are used as rescue, but they used it as first line. So when you do your first laryngoscopy itself, you use a tube either with the Bhuji or you use with tube with the endotracheal tube with the stylet. And the main results of the Bhuji trial, and their primary outcome was success at intubation, first pass intubation success, and close to little more than 1,000 patients, more than the Stiletto trial. There was no difference in the primary outcome, which was first pass intubation success, whether you use a Bhuji or you used a Stiletto. So in this randomized trial of 1,100 odd patients, the first attempt success was 80% and 83%, which is quite realistic for ICU intubations. So they concluded that among critically ill patients undergoing tracheal intubation, the use of the Bhuji did not significantly increase the incidence of successful intubation on first attempt compared to endotracheal intubation. So if you take these two trials together, this is the conclusion, as I mentioned, the first attempt intubation success was equal. So if you take the trial of Samir Jaber and you take that's the Stiletto trial and the Bhuji trial together, they are giving you a clear message that definitely Stiletto versus no Stiletto, it's better to use a Stiletto. And if you compare a Stiletto with a Bhuji, then both are again equal. The same group at Vanderbilt had earlier done a study, which was also published in JAMA, called the BEAM study, which was a single center study. And this group is very experienced with the use of Bhuji. And they had actually shown in this small study that the Bhuji was superior to the Stiletto. But this study was criticized because it was a single center study. And in addition to that, the operators were very experienced with the use of Bhuji. And this is why they did the Bhuji trial, which is a global trial, multi-center trial. And they were in this study, they showed no difference. So the clear message for us really is that today when you do a tracheal intubation in ICU, don't just go straight with the tube. Use either a Bhuji or Stiletto, whatever you're comfortable with, whatever you're familiar with, but either of them will increase your chance of first pass intubation success. So these papers, the three papers have really been practice changing. And in my mind, these were the most key papers in airway management that have occurred that have been published in the last year. I'll move on to non-invasive ventilation. And as we know today, when we talk about non-invasive ventilation, it's not just for ventilation, it's a whole therapy. We're talking about peri-intubation oxygenation. So earlier we would just use the conventional face mask when a patient came in acute hypoxemic respiratory failure, and then if he got more tachypneic or work of breathing increased, we would probably intubate him. Today we can use non-invasive ventilation, and we have another therapy in our armamentarium called high flow nasal oxygen, which can be used in patients with acute hypoxemic respiratory failure. So these are the two kind of bridges, I would say, between just the conventional oxygen therapy and tracheal intubation that we have in our armamentarium, and they can actually prevent avoid a tracheal intubation in these patients. And not only are these therapies used for this, but they're also used for pre-oxygenation before tracheal intubation in this high-risk group, because they can give you more superior PEEP compared to conventional oxygen therapy that doesn't give you PEEP. And these patients already have pneumonia, ARDS, etc. In addition to that, this non-invasive ventilation can also be used post-extubation, especially in high-risk patients, to avoid, especially in borderline cases, to avoid a reintubation in these patients and also in COPD patients. Now, before I go on to the studies, I'll just give you a little background, and I'll allude to this review that we wrote with Jonathan Casey and Audrey DeJong. This was published in Intensive Care Medicine in 2020, and I'm just showing you this cartoon because it beautifully tells you the evidence of non-invasive respiratory support. What is the current role? This is pre-COVID, of course. When you use it as an initial oxygen strategy, when you use it during tracheal intubation, and when you use it after intubation. Now, initial oxygen strategy, of course, is when a patient comes in respiratory distress, acute hypoxemic respiratory failure. What is the role of these three modalities? Conventional oxygen therapy, non-invasive ventilation using NIV or high flow. Now, we have had the Floralee 1 trial, which is a French multicentric trial. And this was a randomized controlled trial which compared head-on the high flow nasal cannula oxygen and NIV and in patients with acute hypoxemic respiratory failure. And they found no difference between the two, both in the primary endpoint, tracheal intubation, but in the subgroup of patients where the P to F ratio was less than 200, NIV, HFNO was superior to NIV. But of course, the study was not powered to answer this. So today we can say that both strategies are equal. If you look at pre-oxygenation before tracheal intubation. So again, we have another study done by the same group, the French multicentric trial. This is called the Floralee 2 study. And what they did, they used either NIV or HFNO for pre-oxygenation before tracheal intubation. As I mentioned, these are high-risk patients not with normal lungs, and you know HFNO and NIV can give more superior oxygenation and improve your safe apnea time, prolong your safe apnea time, just in case you have a difficult intubation, and avoid hypoxia during the during tracheal intubation. And the advantage of high flow nasal oxygen is that you can also use it during, because it's a nasal cannula, you can use it during attempts at tracheal intubation. So clearly we know today that NIV and HFNO are superior to conventional oxygen therapy for pre-oxygenation during tracheal intubation. You can use HFNO during apneic oxygenation. And we have the NEJM trial from Jonathan Casey, which has shown that even in these patients, though we're giving RSI, gentle mask ventilation can be used, because on one side there's a perceived risk of aspiration, and on the other side there is this huge risk of hypoxia. And gentle mask ventilation can overcome this problem and avoid hypoxia, especially in the high risk patient group. So this is our evidence that we have with the pre-oxygenation. So in the Floralee 2 trial, when NIV and HFNO was compared head on, there was no difference between the oxygenation, quality of oxygenation given by either. However, in the subgroup of patients where the PaO2 FiO2 ratio was less than 200, NIV was more superior to HFNO, probably because you can give a higher PEEP and you can give more effective PEEP when you're using a non-invasive mask for pre-oxygenation, rather than when HFNO is used. If the patient keeps the mouth open when HFNO is used, the PEEP is lost. And then coming to post-extubation, we have studies that have shown that in high-risk patients, you can directly extubate onto HFNO or NIV, and this can avoid, is superior to using conventional oxygen therapy. So this is the evidence that we have, which I've just summarized in the pre-COVID era. Again, in the COVID times, the problem became even more serious because we were worried about two things, not only about the patient safety, but we were also worried about the healthcare worker safety, because both these procedures, NIV, HFNO, etc., were thought to be aerosol generating. And so we were very concerned about using this for, non-invasive respiratory support. And the first part of the pandemic, we actually did not use these therapies, and we intubated many patients very early. And we could have avoided a lot of intubations if we had, known that these weren't as, worrisome as we thought they would be in terms of aerosol generation. So then coming to the data related to that. So there's this very nice, elegant study that's published in Annals of Intensive Care. And this is not a COVID study. And what they've used is they've used high flow nasal oxygen cannula versus non-invasive ventilation to prevent reintubation in sepsis patients. So this is a nice big randomized control trial. As I mentioned, the previous trials where we talked about post-extubation were small studies, not very robust studies, not good data. And this was published in 2021. And this was done actually in Thailand, where they did a 1:1 randomization, and they, patients were extubated. These were patients in septic shock or ventilated, extubated, either received NIV or they received HFNO for these patients. And if you can, what the primary outcome was reintubation within 72 hours. And this is the hours from extubation and the reintubation rates. And as you can see, both in the NIV and HFNO group, there wasn't any difference. So in septic patients, they concluded that there's no difference between the use of HFNO and NIV in prevention of reintubation after extubation. And this was in non-COVID patients. So we have a nice randomized control trial with bigger numbers showing this. Now, in the beginning of then what happened is we were dealing with COVID-19, and we really didn't have any data on these non-invasive therapies. We have retrospective studies. We have very few prospective studies, anecdotal, case reports, etc. So I'm very proud to say that along with this team of 39 international experts, I was very happy to lead this Delphi, a global Delphi. Prashant Nasa is part of this, and a lot of other people. And what we did is we said, okay, we don't know what we should use. Should we use NIV? How should we give respiratory support in acute respiratory failure? Let us do a Delphi, and let us get consensus from the masters in respiratory therapy as to how we should use these non-invasive therapies. So this was a global Delphi that we conducted, 39 experts from 20 countries and 6 continents, and this was very early in the pandemic. This was done during the days of the pandemic, and we had a very robust process in place. I won't go into details of that, but to generate consensus, we used multiple choice questions and Likert scales. We even blinded the experts so that there would be no bias and no group pressure. And we took more than 70% for the Likert scale and 80% as consensus for the various statements. And based on this, we generated 20 clinical practice statements. And this is just a summary, which I won't go through in the interest of time. But I'll just tell you every aspect of respiratory support in COVID-19 patients, whether it was non-invasive ventilation, tracheal intubation, awake proning, when to do tracheostomy, how to mobilize, infection control. Every aspect was addressed by these 39 international experts, and that gave a lot of guidance very early in the pandemic. And it's a very, very highly cited article, and I'm really proud to have led this. So just coming to the non-invasive respiratory support, what was the consensus among the experts? That HFNO therapy should be considered as an alternative for oxygen support. HFNO should be used in patients who are unable to maintain their saturation over 90% using oxygen delivery through the venturi mask, and maybe used in patients with increasing oxygen requirement. So we should use it in COVID-19 patients when they're not able to maintain their saturation. And this can avoid the need for tracheal intubation and invasive mechanical ventilation. As far as non-invasive ventilation, they said it should be considered in patients with mixed type of respiratory failure, and also maybe used in patients with increased work of breathing. But they were more in favor of using HFNO rather than using NIV. I know a lot of NIV was being used in COVID-19 patients early in the pandemic, and we really didn't have any data. But the expert consensus was that go for HFNO and NIV more when there was mixed respiratory failure. And there were concerns, of course, about using NIV in these patients. And as we all observed, we saw high tidal volumes. We were talking about PCL. I won't go into the mechanism, but we were worried about patients' self-inflicted lung injury. Many patients were intubated earlier because they were, generating very high tidal volume, and we were worried about the lung injury. And you know that in non-COVID patients, the lung safe study, which is one of the largest epidemiological studies from 50 countries, I'm sure you're all aware of it, it has clearly showed that NIV was associated with elevated mortality when the P2F ratio was less than 150. So we already had this background, but we had no data. And many people were using NIV, especially when we had the problem of oxygen shortage in the country, because HFNO is not a good modality to use if you want to conserve oxygen. So this was a very nice study that was published, and I was very happy to see this. Implications of early respiratory support strategies on the progression. So they looked at all these non-invasive respiratory therapies, and it was not a prospect. It was, a study where they looked at all the patients who got conventional oxygen therapy, who got high flow nasal cannula oxygen, who got non-invasive ventilation, and who got tracheal intubation. And in each of these first three, they saw how many got intubated and how many didn't get intubated. And in each of those categories, they looked at how many were alive and how many were dead. So this was, a very interesting kind of studies, because they didn't do a randomized controlled trial, but it is one of the largest studies that looked at the non-invasive respiratory support. And they screened about 1,400 patients, and they compared these different modalities and looked at the this thing. And what they found was that patients initially ventilated with HFNO compared to NIV, and those with conventional oxygen therapy, compared to the other respiratory strategies, NIV was associated with higher overall ICU mortality, even more than compared to the standard oxygen therapy. 18%, 20%, and 37% even with invasive mechanical ventilation, the mortality was lower as compared to NIV. Perhaps because we were using NIV and keeping it for very long, perhaps we were doing a lot of harm, perhaps there was lung injury, but the mortality overall was higher in patients in whom NIV was used. And in this cohort of critically ill patients, they concluded that a trial of HFNO appears to be the most balanced initial respiratory support. It can reduce the intubation rate compared to the ICU and comparable ICU mortality rate. Nevertheless, considering the uncertainty of the stress associated with the COVID-19 pandemic, both the standard oxygen therapy and early intubation may be a safe approach. And they concluded also that the presented findings are in agreement with the classic ARDS literature. For example, the lung safe study that suggested that NIV should be avoided whenever possible due to the elevated ICU mortality risk. So this kind of study was like a wake-up call that perhaps we should not be using so much NIV in these patients with COVID-19. And this was the first study that showed that there was actually harm. Then we had another modality, and this is the helmet NIV use. And very few centers in India have this. We don't use it at all. much in except a few centers. We don't have it in our site. And this was also another study that was published in JAMA, where they did a head-on comparison between non-invasive ventilation and high-flow nasal oxygen. And they looked at days of respiratory support in patients with COVID-19. And these were patients who had moderate to severe hypoxemia. This was led by Professor Antonelli, and it was Italian ICUs and Spanish ICUs. And they had a very robust protocol for monitoring and when they would consider intubation. So they used this criteria. So it was a very well conducted study, and their primary outcome was looking at respiratory support free days. So helmet NIV versus HFNO, and interestingly, there was no difference in the primary outcome. In a way, that was kind of good news for us because we don't have the helmet NIV. They concluded that among critically ill patients with moderate to severe hypoxemic respiratory failure, compared to HFNO, helmet NIV resulted in no significant difference in the number of days free of respiratory support. So this was one of the large study, over 100 patients done in COVID patients, a randomized controlled trial in the midst of the pandemic. So really commendable, but did not show much difference. I'll move on to COPD and asthma. So people were really concerned actually during the COVID-19 pandemic that are the COPD asthmatic patients, are they at a higher risk of getting, are they at the higher risk with COVID-19? So this was really a concern. And, interestingly, when you look at, and this is a meta-analysis that was conducted of all the studies looking at patients who were asthmatic. And this was published in the European Journal, Respiratory Journal. And this systematic review, when they looked at the risk of ICU admission, and they looked at the risk of, mechanical ventilation in these patients, and also the risk of the mortality in patients who had, and here you can see the funny plot, which is looking at the mortality in patients who were asthmatic. And here they found really that the prevalence of asthma in patients who were having, RT-PCR positive with COVID-19 was about 8% in these control studies. And overall findings suggest that people with asthma are actually at a lower risk of getting infected with COVID-19 compared to those without asthma when the RT-PCR was positive. But if they had similar hospitalization, the ICU admission, ventilator use, and mortality was no different between a patient who had asthma and did not have asthma. And of course, they said with the fast evolving SARS-2 and the emergence of various strains, etc., caution must be maintained. You cannot take this as gospel truth. But it seemed like patients with asthma had a lower risk. And this was again confirmed by another systematic review that was looked at the risk of infection, hospital and ICU admission and death from COVID-19 in people with asthma. And the evidence suggested that there wasn't, with this studies, and this included more studies than the previous meta-analysis. And they suggested that there isn't an increased risk of acquiring SARS compared to those without asthma. And, if not, there was a slightly improved clinical outcomes in patients who had asthma and who developed COVID-19. But of course, these results have to be taken with caution because the strains are changing and the pandemic is still evolving. Now, coming to, this is another meta-analysis. There were a lot of studies that looked at COPD and asthma patients because people were worried these patients, they already have this chronic morbidity. So are they at a higher risk? Do we need to do something different for them? So this is a meta-analysis that looked at, both underlying asthma or COPD. This was again a systematic review and a meta-analysis. And they looked at ICU admission. And they also looked at overall mortality. And you can see this, you can see the forest plot. I won't go into details about the trials that were included, but compared to asthma, COPD was, more of a concern. And COPD was significantly associated with worse COVID-19 related hospital admission and ICU admission and mortality. And even when they had made the adjustments for at least the other comorbidities. On the other hand, asthma, when the pooling results were adjusted for the comorbidities, was not associated with a higher risk of COVID-19 related hospitalization or even ICU admission. So that is a very interesting study. And this was also, there were several other studies, and this is a meta-analysis that's only looking at the studies with COPD and risk of outcome and this was a systematic review and meta-analysis. I won't go into too much details, but here you are looking at the ICU admission and you can see the forest plot, and also looking at the mortality in these patients, non-COPD versus the COPD versus the non-COPD. And patients with COVID-19 with COPD demonstrate increased odds of being hospitalized, requiring ICU admission and mortality compared to COVID-19 who don't have COPD. So this is an important message that these patients are at a much higher risk, and there should be various healthcare measures to protect these patients and take extra care to prevent them from getting infected, because they seem to have worst outcomes and increased mortality when they get COVID-19 and require hospital and ICU admissions. Now, this was a non-COVID study. This was published in Chest. I thought this was a very interesting study. And this looked at personalized variable versus fixed dose of corticosteroid. I'm sure all of you must be knowing about this study in hospitalized patients and in patients who have acute exacerbation of COPD. Many of these patients may come to your ICU. And this was a prospective, multi-center, randomized, open-label study and a large trial. So when they talked about, fixed dose, it was giving about 40 milligram of prednisolone. They screened more than 1,000 patients and then randomized 248 patients. So it was an RCT that was published last year. And, close to 120 patients in either arm. One got, 40 milligram prednisolone, and the other was, and this is when they had an acute exacerbation of COPD. And the other arm, it was, not personalized. So, you could titrate the doses of the prednisolone that was given. And very interesting findings. It's very interesting that in the personalized dose, those who got receiving 40 milligram or less had a great higher failure than those compared to those who received more than 40. So in the individualized, personalized dose corticosteroid group, this seemed to be more effective, but when the dosing was more than 60 milligrams. So the personalized dosing of corticosteroids in patients with COPD exacerbation reduces the risk of failure because more patients provided with higher initial dose. And what they found was patients were getting more than 60 milligram dose, whereas 40 milligram or less was either too low in either of the groups. So even if you had a personalized approach, if your dose was less than 40 milligram or less, those patients did not have a good outcome. So probably this randomized controlled trial shows that perhaps we need to titrate or even do dose adjustments with our corticosteroids and individualize our therapy rather than have a fixed dose for all. Coming to the ARDS studies, again, a lot of data on just COVID-19 studies. And in the beginning of the pandemic, there were no randomized controlled trial. And again, going back to the Delphi we conducted because we, tried to get expert consensus among the global experts on different aspects of managing ARDS. Now, whether COVID-19 is ARDS itself was a question in the beginning of the pandemic, because people said it's not ARDS, it is ARDS, it's ARDS-like. So this itself, we had to have a consensus. One question was whether you agree that COVID-19 is a subtype of ARDS, and there was consensus for that. So we, in this Delphi process, I won't go into details of how we did it. As I mentioned, we got consensus on various aspects of management of COVID-19 ARDS. And I'll just give you a very quick overview of the consensus that we generated. Now, regarding lung protective ventilation, first, if you agree that COVID-19 is a subtype of ARDS, then you have to accept protective lung ventilation, which is, the routine practice in patients with ARDS. So there was consensus for lung protective ventilation should be used, and the target should be 6 ml per kg, and the usual what we're using for the lung protective ventilation. Recruitment maneuvers may be considered only in select patients. The consensus was against the routine use. Neuromuscular blocking agents, they agreed to use it early in the phase of invasive mechanical ventilation and when there was patient-ventilator dysynchrony. Prone position in patients with COVID-19 related ARF on invasive mechanical ventilation and should be used for a duration of 16 to 24 hours per session to improve oxygenation, but they didn't comment on the outcomes because there was no randomized controlled trial until then. The COVID-prone study hadn't got completed. And regarding veno-venous ECMO, they said this may be considered in patients with refractory hypoxemia on invasive mechanical ventilation who don't respond to other adjuvant therapies. At that time, there were also a lot of ethical concerns because of, unavailability and, concerns about whether we should put patients on ECMO at all. But by this time, people had started using more and more of ECMO, and even in India, and there was general consensus that ECMO should be used, when they fail to respond to other, adjuvant therapies. I won't go into infection control, but weaning for mechanical ventilation, they said weaning should not. So earlier people used to delay weaning because they were worried about the exposure and threat of and the risk of reintubation. They wanted to be absolutely sure this patient is ready, but they said weaning should not be delayed and it should be done like you would do for non-COVID patient. And they recommended a pressure support trial for 30 minutes to 2 hours may be preferred over other weaning strategies rather than just putting on TPs, or they preferred a pressure support wean. Regarding tracheostomy, there was already a global Delphi that was done that said do it after 10 days. But by this time, practices has evolved, and the global consensus among the experts was that the timing of tracheostomy to facilitate weaning from mechanical ventilation should be the same as in non-COVID patients. And regarding the technique, they said percutaneous dilatation tracheostomy with or without guidance should be used, either using ultrasound or bronchoscopic management. And this should be preferred over the other techniques for COVID-19. And the other study that I'm very, very proud to be a part of, which was a very important study that was done during COVID in the midst of the pandemic, and India was very, very much involved in it, is the COVID steroid 2 trial. And this was published in Jama. I'm very proud to be the second author on this paper. And this was, again, a great story of global collaboration between Denmark and India, Scandinavian countries. And this was led by Professor Anders Perner, and I led the study from India. And we already had the results of the recovery trial. All of you are aware of the recovery trial, and it showed clearly that steroid was corticosteroid versus not giving corticosteroid. There was a clear benefit, a mortality benefit in COVID-19 patients. The only thing was at that time we used 6 milligram was used during the recovery study. So there was no head-on comparison with other corticosteroids or even with the dose. If you see in India, many people were using methylprednisolone. And if you look at 6 milligram of Dexa, what we were using was very, very high. And, there has been no head-on comparison with the different doses. And this triggered this study from Anders Perner. And I'm very happy to say that close to 50% of the patients in this trial come from India. It is the largest randomized controlled trial, the first randomized controlled trial, I'll say, with such big numbers that India has participated. And I'm really, really proud to share this with you. And this was in the COVID ARDS, where 6 milligram versus 12 milligram was compared. And it was a randomized controlled trial. And what was done is steroids were given only in patients who had severe COVID, who were oxygen dependent, not non-oxygen dependent. So either they were on high flow, conventional oxygen therapy, or intubated, mechanically ventilated. So they got either 12 milligram dexamethasone or 6 milligram dexamethasone. And for the same duration, like in the recovery trial, many things were pretty similar between them. And if you see, the primary outcome was number of days alive, 28 days. And you can see there was a trend to a better, this thing with 12 milligram. And they also looked at the 90 days. So there is a separation, and clinically 12 milligrams seemed to be better without any increased risk of complications. However, when we looked at the p-value, there was no difference between the 12 milligram and 6 milligram. This was actually a very important message for India because we were using very high dose of steroids. So perhaps a lower dose of steroids, even if you use 12 milligram, it was much lower than the equivalent doses of methylprednisolone that we were using. And we faced, we did face a heavy price during the second wave with the mucormycosis and other complications resulting because of the immunosuppression related to the steroids. So this COVID steroid 2 trial clearly showed that there was no difference. And this was a very important study to do because the next question was, okay, we know steroid versus non-steroid is good, but what about the dose? How much should we give? Why 6? Why not more? So, you can also use 12 milligram, no increased complications. But again, it depends on your setting. If we're in India and we have concerns about infection, perhaps you're better off with a 6 milligram dose, but there's no difference. So the real message from this study was that the study randomized 1,000 patients, and compared with 6 milligram of dexamethasone, 12 milligram dexamethasone did not statistically reduce the number of days alive without life support. We've also done now the 180 days data has just been analyzed, and we have similar results. There's no difference between 6 milligram and 12 milligram of dexamethasone in patients with severe COVID-19 and severe hypoxemia. Now, regarding awake proning, does it reduce the work of breathing in patients with COVID-19? And this was a study that was done. There were many studies. We were all practicing awake proning, either using high flow or NIV or some even conventional oxygen therapy. But awake proning was practiced. We did see improvements in oxygenation, but we weren't really looking at objectively at work of breathing. We didn't know whether there was an improvement in outcomes. And this was a study that was published in Annals of Intensive Care, which was a multi-center study and actually showed improvement not only in the P2F ratio, improvement in oxygenation, but also decreased work of breathing in these patients. And what they used was they used the helmet CPAP. It was not NIV or it was not high HFNO that they used. So awake prone position with the helmet enables reduction in the work of breathing and improvement in oxygenation. So they looked at both oxygenation and work of breathing. So clearly a benefit of using, awake proning using this non-invasive respiratory support. A small study, but still, useful data. Then we've already had a discussion on metabolic syndrome, so I won't talk about that. But metabolic syndrome and ARDS in hospitalized patients, this was again published in JAMA, the open access journal. And what they looked at, and this was a multi-center study, and the question they ask is that if a patient, what is the risk of a patient with ARDS and death in patients with COVID-19 who had metabolic syndrome? And again, when we say metabolic syndrome, they had clearly defined criteria. They had, this included either obesity, diabetes, hypertension, dyslipidemia. You have to have at least 3 or more of these criteria to call it metabolic syndrome. And in this cohort of studies, now this was a very big study that was conducted by SCCM, multi-center global study. Close to 50,000 patients who were hospitalized for COVID were included in this study, and they saw the increased risk in patients who had metabolic syndrome. So the findings from this study, I won't go into details about the numbers, suggested that metabolic syndrome and its associated comorbidities were critical risk factors associated with COVID-19 related ARDS and death. So these patients are clearly at a risk, and this was probably one of the largest studies, including almost 50,000 patients, that was conducted by the SCCM trials group in patients with ARDS and COVID-19. Just some studies I'd leave you with for ARDS, and this is about stem cell-based therapy. A few studies, about 27, there's a meta-analysis, about 7-8 of them are just case reports, but they've actually shown a benefit without increase in complications. And this may be something, to think about, not for immediate outcomes, but also for the long-term outcomes and the delayed sequelae that we're worried about with COVID-19. And, I was interested to see that there's already a systematic review done on this topic, and there are already many studies that are showing promising results. So in addition to standard care treatments with COVID-19, there is supportive evidence that adjuvant therapies to reduce mortality rates, and they can even improve the care in these patients. So this is something perhaps to consider for the future. But of course, one has to think about the cost concerns, the feasibility, and the logistics of doing this, but something definitely promising for the future. I'll just go very quickly through pulmonary embolism. And pulmonary embolism, as you all know, people were concerned about. It was more anecdotal. People were talking about there's more DVT, there's more pulmonary embolism in these patients, and it was thought to be a cardiovascular disease. So there were several studies that were done looking at the incidence of venous thromboembolism, looking at VT, looking at the bleeding risk, because we were giving very high doses of anticoagulants to these patients, not the conventional doses. Early in the pandemic, we were giving higher doses of enoxaparin because we were concerned about DVT and pulmonary embolism. So this is a systematic review and meta-analysis that looks at the incidence of VT and bleeding among hospitalized patients. Almost 37 studies were included, and many, thousands of patients. And what they found was, I'll just put you quickly through the results of the study. 49 studies were finally included in this meta-analysis, and they found that among hospitalized patients with COVID-19, the pooled incidence of VT was about 17%, higher rates with routine screening inclusion of distal DVT and subsegmental PE in critically ill patients in prospective studies, and bleeding events were about close to 8%. and was sensitive to the use of escalated dose of anticoagulants, which is what we were doing at that time. And they said additional studies are required to assist us in the significance of the various thrombotic events that occur. Now, further meta-analysis, many studies looked at the prevalence, clinical features of the pulmonary embolism in patients with, with acute onset COPD. And when they looked at this, they looked at the prevalence for the acute onset COPD and pulmonary embolism. The prevalence and the mortality in patients who develop acute onset COPD and develop pulmonary embolism. So if you look at the prevalence, and here these are the studies in this meta-analysis that were included, and if you look at the mortality in those patients who had pulmonary embolism, and this is those who have an acute exacerbation of COPD. And clearly, as you can see in this meta-analysis, the prevalence of PE and COPD acute onset was about 17%. And when this, patients who had this condition showed dyspnea, pleuritic chest pain, higher heart rate, lower limb symmetry, DVT, etc. And they also found that pulmonary embolism is associated with higher mortality when you have severe COPD exacerbation in patients during ICU admission. So patients who had acute exacerbation of COPD with pulmonary embolism had higher incidence of mortality was seen in these patients and this meta-analysis. Now, the other question was, does the pulmonary embolism in critically ill patient worsen the in-hospital outcomes? Because that was what we were worried about. That is the mortality higher in those patients who have COVID-19 with or without pulmonary embolism. And is this any different? So here, this is again a systematic review and meta-analysis that looked at mortality with and without pulmonary embolism in patients with COVID-19. And here you can see the forest plot, and this favors, and this is the control. And these are the various studies. There are about 9 studies that were included in this. And they concluded that pulmonary embolism in critically ill COVID patients had similar in-hospital mortality and outcomes as compared to without pulmonary embolism. And these findings are hypothesis generating, and they are observational studies. So it's not all randomized controlled trial that were included. So they need confirmation, but this was a big concern in the beginning of the pandemic, that incidence of PE is higher, DVT is higher, we should give higher doses of anticoagulant. And I think this study really nailed it. That was published in Jama, and this was a randomized controlled trial where they looked at intermittent dose versus a standard prophylactic dose, where we were using enoxaparin of 40 milligram of enoxaparin versus 1 milligram per kg. And this was a randomized controlled trial, multicentric trial, and they looked at the effect of this on the thrombotic events and extracorporeal use of ECMO and mortality in patients with COVID-19. I won't go into much detail about this trial, but as you can see here, you can see the the hazard ratio, and you can see the intermittent dose and the standard dose of enoxaparin, and you can see there was really no difference in the probability of the primary outcome. And here, the all-cause mortality was the primary outcome, and there was really no difference between using the intermittent dose or the standard dose. And this was really a practice-changing paper published in JAMA. So, so we started using our routine dose rather than using the high dose. And this was done multicentric, as I mentioned, and it was looking at your 30-day mortality, close to 600 patients. And the results of this study, randomized controlled trial, did not support the routine empirical use of intermittent dose prophylactic anticoagulation in unselected patients. So in select patients which were at a high risk, it was a different story, but routine use just because the patient has COVID is not recommended. So this really was practice changing, because I think we had a lot of bleeding episodes as well, and people were very worried about DVT, PE, and they were using very high doses of anticoagulant. I'll move on to a few papers on the oxygen strategy. If you permit me, I've just combined both these things in the interest of time. So I'll just move on to oxygen therapy. I know the chairpersons are different, but perhaps I can take the questions at the end in the interest of time. So some very interesting papers on oxygen therapy. Now, conventionally, any critically ill patient, we always like to give oxygen to the patients, right? Because we feel let's give oxygen, this is, what can't cause harm, and why not give oxygen and make sure the patient's fine. So this is a very large trial that was conducted where they looked at the effect of conservative oxygen therapy in reducing mortality in critically ill patients. So this is a meta-analysis of all the trials that have been there till now, and very, very important question, because routinely we just give oxygen to all our patients. So what they mean by conservative oxygen strategy is that you give oxygen only if the saturation goes down below 88 or below 90, and not otherwise. And you also, the other strategy is you give up to 6 liters of oxygen to these patients. And these are critically ill patients, because in ICU, we always give oxygen. So the question is, do we really need to give oxygen to all our patients? And this is one of the largest meta-analysis that has been done. And if you look at the mortality, there was no difference, but they also looked at the length of the mechanical ventilation, and you can see that there is a clear benefit when you're using a conservative approach. They looked at organ failure. They new organ failure in the ICU. They looked at new infections in the intensive care unit, and they also looked at the use of renal replacement therapy, and this was significantly less in patients in whom conventional conservative approach was used. And they concluded that a conservative oxygen therapy did not reduce mortality, but it decreased the time length of mechanical ventilation, new organ failure, and risk of renal replacement therapy in critically ill patients. So this is really a paper that there were a lot of limitations. I won't go into details of that, but it's clearly questioning whether we need to give oxygen to all patients, or we can just target a saturation, and if the patient is fine, we need not give oxygen routinely to all critically ill patients. This paper is a meta-analysis, a study that goes one step further, because it looks at avoiding routine oxygen therapy, not just in critically ill, but patients with myocardial infarction, where we would never even think of not giving oxygen. And they have even shown a cost benefit. It saves significant expenditure for the healthcare system. And this was a study, it's called the Detox 2X AMI trial. And this was done in Sweden. It was a multi-center trial that was done by these Swedish investigators. And what they did is, in one arm, they had a conservative oxygen strategy, and they didn't give oxygen to the patient unless the saturation dropped. And in the other arm, they gave oxygen to the patient. And these were patients, mind you, with acute coronary syndrome, right? They could be in the ambulance, emergency department. So this was the kind of time from the initiation to the termination of oxygen therapy and hospitalization. What you see in red is the oxygen therapy, and the blue is, the patients who just received ambient air. So even if they had ECG changes, or their troponins were positive, or they had, symptoms, still, if the saturation was fine and they were okay, they were not given oxygen therapy. So large number of patients, and they screened, they randomized close to 6,600 patients. So almost 3,000. So this is a very, very big trial, and I really wonder about the ethical clearance for this trial. And they concluded that avoiding routine oxygen therapy in patients with suspected or confirmed MI without hypoxemia. So if there was no hypoxemia, just because they had, patients with suspected or confirmed MI, it was not necessary. And it also saves significant expenditure for the healthcare system with regards to the medical and the human resources. So these two are really, I would say, practice-changing paper. Taken together, I would say that in select cases, of course, we may need to give oxygen even if in critically ill patients. But otherwise, we can, if there's no hypoxemia, routine use of oxygen, giving everybody oxygen is really not required today. And we have good data to support that, even with the limitations in these trials. Coming to weaning, I just have a few more slides, just 2-3 more slides. I promise to keep to my time. So coming to weaning, not many trials, but this one study I found very interesting. This is a meta-analysis that was done last year. Methods of weaning from mechanical ventilation in adults. So this was a network meta-analysis, and they looked at all the weaning, different types of weaning modalities, including the automated ones like smart care, proportional assist ventilation, ATC, all the different things. And they compared the weaning success, that is not getting reintubated in 72 hours, or reintubation rates, and also the mortality with the different kind of weaning methods that we use. And this is a very interesting graph. And you can see all the different modalities are there: smart care, ATC, ASV. And you can see where there are more greens, they are better. because they're looking at mortality. This inner circle is mortality. They're looking at reintubation, and the outer circle is a weaning success. I found this a very interesting graphical representation. As you can very clearly see that the PAV seemed to be the best, followed by the smart care, because there are more greens and less of red in this. I won't go into detail of this, but compared to all these weaning modes, what they found in their network meta-analysis was weaning with proportional assessment, ventilation and smart care resulted in higher weaning success. And in addition to this, PAV reduced the reintubation rates and mortality in a comparison to other modes of weaning. And we hope that this evidence about the benefit and the risk when choosing will help the clinicians. Of course, we need more studies. Not all were randomized controlled trials that were included, but definitely it gives you some comparison and some confidence in using these modalities and considering them to probably be superior to our conventional ways of weaning the patients. There's another very interesting study that comes from Karen Burns. Unfortunately, I was not able to get the full text of this article. And, I'm just going to leave you with the abstract. I have read this paper, but I was not able to, somehow get this article, the full text. And this looks at non-invasive ventilation versus invasive weaning in critically ill patients. And it's a systematic review. And this was published in Thorax, big study with big names. And Karen Burns is the first author from Canada. And what they did is that they did this meta-analysis and systematic review looking at, extubating to NIV and looking at outcomes in these patients. And there were 28 trials, almost 2,066 patients. And interestingly, almost 50% of them were the COPD patients. These are the patients that, extubating a patient, put a patient with COPD on invasive mechanical ventilator is really a nightmare. So perhaps, extubating them early on non-invasive ventilation, almost half were COPD patients. And what they found was in this meta-analysis, they found that non-invasive weaning significantly reduced the mortality, pneumonia, and also the duration of ventilation related to weaning, particularly in patients with COPD. And the beneficial effects are less clear or more careful, perhaps more careful patient selection is required, but this definitely gives confidence regarding the superiority of extubating to non-invasive ventilation, especially in this high-risk group like the COPD patients. And this is perhaps one of the largest meta-analysis that has been done looking at this. And I thought this was a very interesting study that was done, and also non-COVID for a change. Coming to a mechanical ventilator, and just 2-3 more slides I have left. So there are a lot of studies, looking at different types of automated, extubations, looking at different types of, artificial intelligence for mechanical ventilation, small studies, few randomized controlled trials, but I didn't want to include this. This is a study that has been published in Nature, and it looks at the etiology, incidence, and outcomes of patient ventilator synchrony in critically ill patients undergoing invasive mechanical ventilation. Very nice, robust study that is done, single center study from Mayo Clinic. And they looked at patient ventilator asynchrony in critically ill patients who were invasively mechanically ventilated. And very interesting, if you look at the, this is the overall, patient ventilator asynchrony, and among the different types of, flow mismatch, cycle mismatch, it was a double triggering that occurs most frequently. And they did this in almost over 600 mechanically ventilated patients were included in this study. And I won't go into details of this, but they concluded that, patient ventilator asynchrony with double triggering and flow starvation account for most often the, critically ill patients undergoing at least 12 hours of invasive mechanical ventilation. And they found that the occurrence of this was associated with worse outcome, and including fewer hospital-free days. And patients' characteristics included days of mechanical ventilation, and etiology of respiratory failure also was responsible. And this may, sort of predict how one develops the patient ventilator asynchrony develops. And so we need to identify risk factors. But definitely this is a very interesting investigations, and they feel further studies are required to determine whether the relationship between patient ventilator asynchrony and outcomes is just a association, or it's it's causal. But I thought this was a very interesting study, large number of patients in which they had looked at. I'll leave you with the study, and again I'm very proud to be part of this team. that published this paper in Critical Care. And this looks at personalized mechanical ventilation in ARDS. And of course, in patients with ARDS, we are always talking about protective lung ventilation. It's one of the strategies that stood its test of time. And we know we give lung protective ventilation, 6 ml per kg, or even lower in these patients. But the time has come. We know that ultimately, we need to look at the driving pressure. And to look at the driving pressure, we have to look at the esophageal pressure. We have to look at mechanical power. We cannot just give one PEEP to all our patients. We can't just use the PEEP FiO2 table that we're using with the Ards Net, the AMRICON trial. So the time has come where we have to use all these knowledge from these trials, and we have to use a very personalized approach to ventilating our patients with ARDS. And it has to go beyond just the Ards trial. And I urge you to read this trial, and I'm not saying it because I'm a co-author on this, but it's one of the most beautiful reviews where all the studies related to, individualizing and personalizing mechanical ventilation in ARDS has been discussed in detail, including strategies on how you could use, your mechanical power, individualize your PEEP, and things like that. So I'll just leave you with this study because there weren't too many trials on mechanical ventilation that I could find. So I'll end here. Thank you very much for your attention. Wherever you are listening to me, do take care and stay safe. Thank you. I'll just stop sharing my screen.